Up next, we're going to move to that rapid fire talks, our flash talks. And I'm going to have Jenna Mulder. Are you here, Jenna? Oh, great. She's going to come up and introduce herself, and she's going to be talking about diaphragmatic pacing.
Hello. Thanks for having me today, guys. So I should say my name's Jenna Mulder. I am the clinical nurse specialist in the trauma and neurosurgical ICU at St. Mike's Hospital. I've been nursing for approximately 12 years, most of my time spent at St. Mike's. However, doing a variety of different roles such as TGLN, organ and tissue donation coordinator, so I thoroughly enjoyed Dr. Singh's talk just now. I recently just came into this role about 6 months ago, so happy to be back at St. Mike's. And so what we're going to talk about today is just allied health considerations regarding diaphragmatic pacing. And so full disclosure for everybody in the room, I am not an expert on diaphragmatic pacing. I was a little bit sort of thrown when I was asked to come and speak about this today because our patient who we recently had came to the Western to have his implant placed. And so what I really wanted to focus on today was just a case study of our experience with this patient. Okay, so we'll get started. Our patient was a 31-year-old male. He sustained a C2 dense fracture, otherwise healthy, admitted in our early summer season. He had a dirt biking accident, was doing tricks on a hill, was thrown from his bike, had a hyperextension injury, and subsequently had that fracture. He came direct to us from scene and was surgically fixated in about 24 hours after admission. In the days following, he was a little bit hemodynamically unstable, requiring active resuscitation, aggressive pressors, and had some flaccid paralysis with absolutely zero evidence of respiratory effort. He was trached with us on day 8, and even though he did start to have some improvements from a motor and sensory perspective from his injury, he was still having no respiratory drive or no respiratory movement. And so where do we go from here? So what I will say about our patient is that he had a super strong family support network. Even though he lived far away from his parents and his family were able to drop what they were doing and be at his bedside on a regular basis and truly advocate for him. His sister, in fact, was in the medical field, so I think that definitely helped his cause quite a bit. And so just a little bit about diaphragmatic pacing. It was developed to replace mechanical ventilation through laparoscopically placed intramuscular diaphragm electrodes. Basically, there's 4 electrodes that's implanted into the diaphragm. Once we actually map out the phrenic nerve, we can spot the exact right places in which to implant those electrodes to get the most maximum contraction. There's a 5th cable that's placed as a grounding cable internally into their abdomen, and then there's an external wire. The wires become externalized, and for our patient's sake, it was in his right upper quadrant. And so the notion of looking into diaphragmatic pacing for this patient actually came up organically with discussions with his sister as well as discussions with our team. And so with really excellent collaboration with the team here at Toronto Western, primarily Dr. Singh and Dr. O'Kranick, I hope I said that name properly, we were able to facilitate this interfacility transfer. He was able to come here and have an assessment and subsequently had this pacing implant done at 44 days post-injury. He came back to us in TNICU approximately 2 days later, and I will say his family and himself were very impressed with the care that he received at Toronto Western, so thank you very much. And so now what? We've got this patient who showed back up at our door. We've never really seen this before. Where do we go from here? And so in addition to his externalized wires, this is what he came back with, which was a setup for 2 hole pacing systems. And so we really tried to just approach this as we did with any other device or intervention, which is sort of just a knowledge translation, educational initiative for our staff, our interdisciplinary staff, because this did include everybody. We did a literature search, which if any of you have ever done, you'll know that there's very little on this because of how rare this type of injury is that would be amenable to diaphragmatic pacing. We were able to collaborate with UHN to discuss weaning and what might be a great strategy for this patient. And lastly, we worked a little bit with the representatives from Synapse who were really wonderful to work with and provided us a lot of educational materials as well as hands-on materials to be able to train our staff. So we did a lot of hands-on demonstration, primarily with just the changes in securement device and site maintenance. We created a quick reference binder that stayed at the bedside, which actually subsequently ended up turning into more of a journal for our patient and family, so they could sort of share with us what the day-to-day what their day-to-day thoughts and feelings were, if he had a good day today, if he had a bad day the next. Overall, it really wasn't about the complexity of this, and if anybody who's ever seen this actually in person will know it's not a very complex device. It actually looks really low-tech. Our patient somewhat likened it to his Game Boy that he had when he was a child. And so it was just about normalizing the wires, normalizing the use of the pacer box, setting up the appropriate schedule for just basic maintenance, such as battery changes, et cetera. We created basic troubleshooting sort of as what if. That was always the next question. So what if the wires slip? What if the box malfunctions? What if this happens? What if that happens? And really, as many of you know, it's just your basic ABCs, right? If something happens with the box, we treat him as we would treat him any other time. If he has respiratory distress, we would intervene as necessary. The family and the patient were engaged so much, and we were so thrilled to have this, and a lot of our focus was actually making sure that the family were comfortable with managing this device, because obviously we really didn't have any ideas to the duration of this therapy that he would require. And so the likelihood of him going home with this, with him leaving the ICU, we really just didn't know. So we wanted them to be knowledgeable and comfortable, thinking that long-term they could be the ones managing this device. When it came to weaning, we really did a basic trial, much like you guys do here, where we would do 1 hour a day, off vent, on pacer, and then let him rest for the rest of the day. And we subsequently increased that day by day, hour by hour, which then went to 2 hours and somewhat 3 hours a day of an increase per day. And he did incredibly well with that. He didn't have any regression whatsoever. However, he felt, particularly in the initial phases of his weaning and being on pacer, really it was anxiety-provoking for him. He felt like he was trying to learn how to breathe again, and how do you even begin to describe what that feels like? He did say he could feel, obviously, the impulses caused by the electrodes. Although they weren't painful, they were just constantly present, like a nagging sensation. Overall, for him, distraction, spending time with his family were very beneficial for him. And so what happened with him? Ultimately, he was successfully liberated from a vent in 22 days post-implant. There were 0 reports of any technological malfunctions, anything wrong to do with the pacer. Between day 22 and between day 37, as you'll see up there, we noticed that he was at times breathing above the set rate on the pacer, as well as breathing when we had to disconnect the pacer for any maintenance. And so on day 37, we did all diaphragmatic ultrasounds, saw that there was spontaneous diaphragmatic movement, better so than when he was actually on the pacer. And the decision was made at that point to turn the pacer off and see how he went. And he flew. He never had to have the pacer reconnected back on him again. And the next day, we're actually able to transfer him to our inpatient unit. And then, of course, subsequently on day 101 post-injury, he was able to be transferred to rehab. So what does this mean for us? What did this mean for the patient? We were thrilled with the success of how well he did, and so was his family. His family said that this was beyond their wildest sort of hopes when we decided we were going to pursue this therapy. Lost my spot there, hold on 1 second. So he was able to phonate with trach mask trials almost immediately, which drastically improved his mood and communication, I'm sure, as you all can imagine. It was like day and night from one day to the next, the minute he was able to sort of actually communicate with us, because he was not a great lip reader, if anybody here remembers. This guy had the pleasure of meeting him. He passed his SLP testing the same week that he was fully liberated from the ventilator, just in time for his birthday. He was able to take normal food, have his birthday cake, perhaps had a drink of something a little bit more stronger than just water. And of course, he was incredibly thrilled with that. And so we were happy. We're successful with this one patient that we had, but now what? These are incredibly unique, rare circumstances that we see. The thought was as well, he was able to successfully liberate from the pacer in a really short period of time, actually, you think 37 days post-implant. So would he have been able to wean from the ventilator without the pacer. And I think as a whole, when we look back and reflect on this, we think, yeah, of course, he probably likely at some point would have been able to. But what role did the pacer play, right? There has to be some consideration that we give to the fact that we really didn't let his diaphragm atrophy and started to move it and activate it even when he couldn't intrinsically do that. And so the impact to that was definitely a beneficial one for him. But now what do we do for other patients? On a whole, we see about 35, 36 patients, spinal cord injured patients at St. Mike's per year. Certainly not everybody is going to be a candidate for this intervention. And so how do we make sure that this still does come to the top of our mind anytime we do care for our spinal cord injured patients? And so we're in works with developing our spinal cord injury guidelines, our internal guidelines, and so trying to see how this fits in appropriately within those as we move forward. And that is what I have. Thank you for listening. Any questions? Yeah. Mm-hmm. Yeah. Mm-hmm. Mm-hmm. That's a really excellent question. I don't know of any off the top of my head. I know there is some discussion about some of your physicians here working towards that because they are the experts. When you really do literature review, there's very little out here, and really they're case reports, primarily out of the US, small sample size, with wide variations. And so RTCs would be obviously ideal, but just given the fact of how rare this is, I don't know how feasible that might be. Yeah, awesome. Thank you, guys.
Our next talk is actually on inter-rater reliability, rater reliability study of the visual pupil examination comparison to Pupilometer. So is our speaker here? Wonderful. Thank you. I'll have her briefly introduce herself and then get started.
Good afternoon, everyone. My name is Shai. I am a nurse at the MSN ICU at the Western. So my co-investigator, Kitty Chung, could not be here today, so I'm going to be doing this solo, so bear with me. So first of all, thank you to the committee for inviting me here today to speak about our Crumble project. So our Crumble project is called Inspect, and what motivated us to start this project is, I'm sure most of us with a neuro background can relate to this, is when we're in the, we're checking our patients' pupils, and sometimes we have a very hard time deciphering what the people could tell us, whether it be, I might see one thing, and then my colleague might see another thing, and especially when you have a vulnerable population, like we do in our ICU, it becomes a bigger problem. So it was challenges like this that Kitty and I kind of encountered on a daily basis, which motivated us to pursue this project. So this is kind of just a little overview of what we're going to be going through with today. So the Peopleometer, I know Greg is here from Surgeon One, so he can definitely speak to that a lot more than I could. So feel free to check out the Peopleometer, it's right there. So this is a handheld device, and I'm sure some of you may have used this in your practice before, but for us at the Western, this is completely new. So it's a handheld device that gives you an objective reading of your pupillary size as well as the pupillary reactivity to light. So it uses a bunch of fancy variables such as like your constriction velocity, your latency, pupil size, to kind of formulate this quantitative number that is your pupillary reflex to light. So it uses the neurological pupil index algorithm. So the 3 to 4.9 is your normal pupillary reflex. So that's what's ideal. So we might say brisk in the clinical setting. Less than 3 is your abnormal pupillary reflex. So sometimes we might say sluggish, which isn't really technically clinically correct, but we still use it sometimes. And if you get a pupillary reflex of 0, that is indicative of no reaction. So that's the Pupilometer, and these are smart guards. So these smart guards are patient-specific, and we attach it to the Pupilometer, hold it at the patient's eye, and it reads your pupillary size, and within about 3 seconds, you get a reading. So why use the Pupilometer? So we did extensive research prior to beginning this project. So what we found is that the scoring of your pupillary reflex is very subjective. So what I see might not be what you see or what you see. So it's very different. And especially when working with a neurologically compromised population or a vulnerable population, it's really, really important that we have a correct pupillary reading. So studies have shown that humans aren't really quick to pick up on pupillary changes, especially on early onset. So when you're working with someone who's really, really sick, this can predispose them to almost death. So the Pupilometer actually provides very accurate and objective readings of the pupillary size as well as light reactivity. It can potentially detect early onset of subtle changes in your pupillary size, which can buy the patient, whether it be a CT scan or early OR, and overall improve the neurological outcomes. So this is a quick case study to kind of really emphasize on the importance of the Pupilometer, or rather the clinical significance. So this is a 70-year-old male who presented to the emergency department with an unwitnessed fall. This gentleman has a history of atrial fibrillation, was on warfarin therapy. So the patient was initially a GCS of 15 and rapidly deteriorated to a GCS of 5. Sorry, just give me 1 second. So they brought the patient to the hospital, they intubated the patient, they took him to CT scan, and on initial consult, they found that his clinical exam showed that his right pupil was dilated and non-reactive, whereas his left pupil was reactive. So that's what they saw. They brought him to CT scan, and he had a massive right-sided acute subdural hematoma with a 17 millimeter midline shift. So as you can see, the portion in the red is the bleed, and the midline shift is so significant that this was detrimental for this patient. So we're worried about this because the subdural is so significant that the pressure has nowhere to go. The blood can't go anywhere in the brain, so he's at risk for uncal herniation, which is brain death, as Dr. Singh had said. So what happened with this patient is they took him to the OR to do an emergency craniotomy and evacuate his bleed. And when this patient went down to the OR, they put him on the OR table and they happened to check his pupillary reflex at the time. And he had both of his pupils were actually dilated and non-reactive. He was also hemodynamically unstable at the time, so they just did not go through with the surgery and they brought him back to the unit. And they planned to send this patient to a neuro ICU to have him tested for brain death determination. So after they brought him back to the facility, they happened to check his pupils 2 hours later with a Pupilometer, and what they found was that his NPI values were 2.6 in his right pupil and 3.8 in his left pupil. So kind of going back to that NPI algorithm, so his right pupil was actually sluggish or abnormal, and his left pupil was 3.8, so that's pretty brisk, so very normal. So it's kind of just like, in summary, emphasizes what we can't see to the human eye is detectable by this technology. So this patient was brought back to the OR after they consulted with neurosurgery, and he had a craniotomy. He had an evacuation of his bleed, and believe it or not, with some time, he had a significant neural improvement, and he just had some, mild right-sided hemiparesis and a third nerve palsy. That's really all he had, and he was brought back home. So kind of just looking at the research done thus far, an older study back in the early 2000s looked at the inter-examiner variability. So that basically just means that, my pupil exam versus my colleague's pupil exam, how different our results are. So this study used the dynamic and static pupilometers back in San Francisco. And they found that when 2 people do a visual pupillary exam, there's a 39% difference, and then whereas a 1% difference when they do a pupilometer exam. And then a study in Dallas, Texas looked at the inter-device reliability of the NPI 100s. So that means that the pupilometer I use and the pupilometer someone else uses, how reliable, how in agreement are the results. And this study found that there was an extremely high reliability amongst the two devices. So this really means that you can start using this interchangeably within the hospital. So Lee and colleagues looked at another study in Melbourne, Australia, and so what they did in their ICU is they implemented these pupilometers. They said, this is great, so they implemented them, but what they found is that no one was really using them. So they started to look at why wasn't, any clinicians at the bedside start using these pupilometers. And so they found that they kind of studied the frequency of uptake as well as the barriers to use. And they found that a lot of people felt like it was a significant tool when they had difficulty deciphering pupils, but they also found that there was a lack of education and instruction on use. And a lot of people were couldn't really understand the clinical significance of the pupilometer. So what our study is going to add, so this is actually the first study to be done on pupilometers within a Canadian setting. So it'd be really interesting to see how our practice standards, our education, kind of our training with our physicians and nurses would, what the take it has on pupilometers. And it's also the first study to look at the inter-rater reliability of the NPI 200. So the previous studies I'd mentioned looked at the NPI 100 as well as the static pupilometers. So that would be really interesting. And the three studies I kind of mentioned previously, our study kind of combines everything together. So I'll get into that as I go into my next slide. But we're kind of a combination of the three studies I previously mentioned. So our study is going to look at the inter-rater reliability of pupillary exams with a visual way of testing, which is our current standard of practice, as well as with the NPI 200. We're also hoping to evaluate whether clinicians, so that be nurses at the bedside, physicians, resident physicians, fellows, find this really useful in their current neurological assessments, as well as if they are confident and comfortable with using this. We're also hoping to look at the inter-device reliability. So, if I have a pupilometer and my colleague has a pupilometer, how reliable are our results? So this is a prospective observational study. So how we kind of do it is we screen for patients who already have a neurological assessment ordered by a physician, and we recruit participants within our ICU who are practicing, and we conduct a standard visual pupillary exam, so just kind of what we do on a daily basis. And then, so I would do one as the investigator, and then my colleague would do one, which is the participant. We record our results, and then we would do one with the pupilometer. So I do one, and then my colleague would do one. And then my colleague would go ahead and do a participant survey, which looks at their confidence and kind of answers our sub-aim. Our sample size, we are hoping to enroll 250 paired readings. Thus far, we have about 20 readings. We just got RUB approval in September after a whole year of waiting. So we have 20 readings in about the last month. So in conclusion, the purpose of our study is to really determine the inter-rater reliability of the pupilometers, and we're really, really hoping to, change the standard of practice right now and kind of implement something that would give us a lot more confidence and a lot more clinical significance in our ICU. So that's really what we're trying to show, and I'm sure with our study, we can definitely go ahead and show that. So thank you, everyone, and if there's any questions, please feel free. Yeah?
I recently came across a patient who had a white pupil.
Oh.
How would you assess that? Would the machine work on a white pupil, first of all?
I personally don't know. I have not encountered that in my study thus far, but that's a really interesting question. I think maybe, I don't know if Greg could add to that.
Exactly, for the machine.
Yeah, so I don't think it would work, but I will ask someone and talk after and follow up.
Okay, so I asked because when I looked on previous assessments of the pupil for this patient, who was blind, by the way, half the people said unable to assess, and the other half actually measured the pupil. And I was thinking, but it's white. How can you measure something white? So
No,
I
I'm,
bet you don't have the answer.
no, that'd be interesting to know. I don't know. Thank you.
For those of you who haven't had a chance to check in with our vendors, this is a great opportunity. If you've not played with a pupilometer, please take the time to play with it. It's a wonderful opportunity to use that as a device. It's so helpful in my own practice. Thank you so much.
Thank you.
Okay, our next talk, again, these are rapid fire talks, is on neuromodulation and spinal cord stimulation and chronic pain. And that's Darcia Paul. Welcome.
Can I ask you a question? Where's the pointer? Good afternoon. I'm Darcia. I'm a nurse practitioner that works here at Toronto Western. My focus is sort of split. So I have a focus in epilepsy, specifically medical aspect of epilepsy with a subspecialty in women with epilepsy. So focusing on pregnant women, helping them through their pregnancy. And the other part of my focus is functional neurosurgery. So for some of you that are not aware of what functional neurosurgery is, it's dealing with neuromodulation, so patients with deep brain stimulation, patients with spinal cord stimulation for management of chronic pain. So I was asked to give a talk about neuromodulation. For some, it's going to be new, so let's go through this. It's a Coles Notes version of what sort of my lens is. So I had the opportunity to partake in a retrospective study on patients that have spinal cord stimulation. And the notion behind the trial was looking at their psychological well-being. So for many patients with chronic pain, they have underlying undiagnosed anxiety and depression. So how are we able to see these patients, help them with their chronic pain, but at the same time manage their underlying anxiety and depression? I have no disclosures for this presentation today. So the agenda, the background, what exactly is spinal cord stimulation? I'm going to look at the project overview, what my project was about, the outcomes of it, and the impact it has on nursing practice and specifically patient care. And then where do we go from there? So based on the retrospective study on what we were able to obtain, what are the next steps after we've obtained them? So the background, what exactly is neuropathic pain? We know that it's not normal, it's not good. It's a change, it's a maladaptive response to someone's somatosensory system, to the way they perceive touch, pressure, pain. So for people that don't have underlying chronic pain, if they get, say, a little simple injury, their response is usually normal. It hurts and then usually it subsides. But for someone that has chronic pain, neuropathic pain, it's an intensification of the actual way their body responds to the pain. So normally, things for like Tylenol, analgesia won't necessarily help with their chronic pain. Characteristics of neuropathic pain include burning, itching. Some patients may feel sensitivity. In some rare cases, some patients may feel brush allodynia. So what does that mean? So say, for example, someone walks past you. For us, it's normal. But for someone that has chronic pain, it may hurt them. They may not even be able to wear a sock, t-shirt. They may not even be able to put their comforter on at night. So it's this maladaptive response to pain. And sometimes patients may feel paresthesia or tingling quality to their pain. So the background behind this leads us into the neuromodulation piece, but for some patients, for example, that have spinal stenosis, they may need back surgery. Ideally, the point of the surgery is to relieve them of their pain. So they may have this radiculopathy, so this shooting pain down their leg. So initially, you have this surgery to relieve the pain, but unfortunately, there's about 15% of patients that don't fare well. They continue to have this pain that starts off from an acute inflammatory response, which is typically reversible, to then chronic neuropathic pain, which is irreversible. So for this subset of population of patients, what do we do? Because we know that with chronic pain, they are oftentimes in the emergency department seeking pain medication and strategies to help deal with their pain. So surgical intervention for any type of pain that is caused by structural abnormality is very important, because our goal is to help, number one, relieve their chronic pain, and additionally get them back into the workforce. We know many studies have shown and suggest that early return back to work improves patient outcome as well as satisfaction and health-related quality of life indicators. So let's go into neuromodulation, what exactly this is. For some people, this is new. They've actually never seen it. So neuromodulation has been around since the 1960s, before I was personally thought of. So it's been around for some time. So if you look here at this screen, there's this device thing that you see along the spinal column. And at the bottom here, there's a battery. So what ends up happening is that patients are literally at the end of their rope in terms of what next steps we take for management of their neuropathic pain. Because you have to think about it. They're getting surgery to help with their pain. So they're at this point where they're pretty desperate. So what happens is the neurosurgeon inserts a lead, which is this here. They remove part of the lamina and they insert it into the epidural space. And it connects to the battery, which is the IPG that you see here. And it's very similar to the TENS machine. I think many of you are familiar with it. So this is the Maserati of the TENS, an internal Maserati of the TENS machine. So the notion behind neuromodulation actually dates back to the mid-18th century, if we think about it. So everything old is pretty much new again. So they took the concept of the electric fish. Patients at that time that had pain, they took the electric fish, they put it on the pain-dominant area, and for whatever reason, it relieved their pain. So with that same concept, they moved it forward into the modern era with a spinal cord stimulation. In Canada, spinal cord stimulation is the approved source of neuromodulation for use of chronic neuropathic pain. We use it in Canada for leg-dominant pain. In the States, very different. They could use it for leg, back, amid other criteria. So you can actually use it for complex regional pain syndrome, patients that have diabetic neuropathy. You can actually use it for angina. So there's many reasons as to why we can use neuromodulation, but specific for today, we're going to talk about it for neuropathic pain. So patients that go through this process of spinal cord stimulation oftentimes have underlying psychological anxiety, depression. For some people, it's undiagnosed. About 20% of patients, it's undiagnosed. And for other patients, it's there, but we need to manage it because we know that if we manage the anxiety, if we manage the depression prior to insertion of spinal cord stimulation, their outcomes are better. So what we did here at the Western, along with Dr. Bhatia and the neuromodulation pain team, is that we looked at a cohort of patients, 30 patients, retrospective study. Half of them were subjected to formal psychological testing, and the other half were not. They sort of went through with it. And we waited and we wanted to see what was going to happen. So the objective of this study was to look at the sample, look at the two cohorts, and look at their validated scores. So patients that went through formal psychological testing, was there any different in terms of their outcome compared to patients that did not? We used validated screening tools to help us guide us throughout our process. So I'm not sure if you guys are familiar with it. There's the Beck Depression Screening Tool. There's the Pain Catastrophe Scale. There's the Patient Health Questionnaire, as long as the general anxiety one. So we use these validated tools to help guide us to determine, yes, a patient can move forward without psychological intervention, or no, they cannot. And our cutoffs are based on the cutoffs provided with the validated tools. So what were the outcomes? So we screened the patients between actually December and July of 2017. 30 patients who went to trial and implant. So it's 2 stages of the surgery. So the first stage is that they actually insert the lead, and then they stay in hospital for up to a week where they test it and they trial it to see, yes, it's going to cover my pain dominant area, or no, it's not going to do anything for me. And if it's a trial failure, then they would explant it and the patient would go home and continue on with conservative management of their pain. But if it's a trial success, then they'll move forward with internalization of the device. So of the patients that went through, 20% of the patients of the cohort, so 20% of the 30 patients, actually bypassed the formal psychological interview. So this was enlightening because many of us believe that there's underlying anxiety and depression with these patients, but many of them are managing. They're doing it. They're doing well. So it allowed us to look at our routine, how we do things in practice, because prior to this, we subjected everyone to formal psychological testing. So the question that came about is this actually necessary? Reports of pain relief for those that have gone through formal psychological testing were not that much different, or actually a little bit less compared to those that didn't require it. So for those patients that were well managed in terms of their psychological well-being, they actually reported higher scores at some point in time. So what does this mean with this information? What does it mean? So if you're the nurse working with the neurosurgeon in terms of neuromodulation, it will affect your practice because the conversation that you're going to have with the patient is going to be very different to someone that requires formal psychological testing. So for someone that doesn't, the goal now is to try to get them through the system to get the neuromodulation implanted. But for someone that requires formal psychological testing, it's just an extra step, not necessarily a step behind, but it's an extra step to ensure that they have the appropriate outcome. So it also allows us to determine, because you ask some patients, how's your mood? Oh, I'm fine, right? But until you do the formal testing, do you realize that they actually have underlying anxiety and depression? So it allows us to pick up patients that are undiagnosed. And interestingly enough, there was a study done, evidence supports that 20% of patients have undiagnosed anxiety and depression, so very alarming. Our goal after all of this is to take all the validated screens, so the anxiety, the depression, the pain scores, and hopefully make our own so that there's one checklist, so patients are not subjected to 4 or 5 different checklists. There's one checklist to validate if they are depressed, anxiety or not, and if they should move forward with the formal testing, etc. For patients, they're subjected to less formal testing. There's a shorter process for waiting for the spinal cord stim if they don't need the actual formal psychological testing. So where do we go from here? Our goal is that this is 30 patients, right? It's quite small, it's a retrospective study. We continue to accumulate patients as our program grows. So we hope to expand it to a larger cohort of patients, and who knows, at some time maybe make it multidisciplinary, multi-centered. So we do neuromodulation as well as London, so we hope that eventually we can do across both sites. We hope to change the way we do things, look at us, give introspection to our process here at Toronto Western. So maybe we need to develop 2 different pathways, right? One for patients that require formal psychological testing, conversely, patients that don't require formal psychological testing. And with the end goal of developing a prognostic clinical tool. So again, taking all the validated screening tools and making it our own, right? Maybe it'll be the Paul screening tool, the Darcy screening tool, I don't know, something that allows us to, just get to a point where the patients are not subjected to so much, because they've been through so much already. So our goal is to lessen their wait and stay. So I'd like to acknowledge Dr. Anuj Bhatia, Dr. Despandi, and Aliza, who's a clinical psychologist, part of the neuromodulation program. Thank you. Yes, Shawna.
Of the 30 patients, what were the outcomes of the spinal cord stim, and were they related to perhaps increased scores on your depression screen and anxiety scores?
So of the 30 patients, still early to conclude. With spinal cord stimulation, it's around 2 years that you'll know if there's efficacy of the device. Some patients may have immediate response. We'll never deem that this gets away their pain 100%. We always quote that up to 50% chance of 50% reduction in pain. So for many of the patients, about 27 of them have had upfront success. For the other 3, they actually did fail the trial in hospital, so subsequently it was explanted. So I think we'll know in about 1.5 years' time to really truly know the efficacy of the devices.
Thank you so much.
Thank you.
Okay, our next talk is on the use of optic ultrasound in shunt patients. Sarah, are you here? Oh, great. And so we'll have Sarah tell us a little bit about herself and then start her talk.
Is this? Hi, everyone. So I'm Sarah Breitbart. I'm a nurse practitioner with the neurosurgery team at Sick Kids. I understand we don't have a lot of people here with pediatric experience, so we'll kind of start from the beginning with some background on this project. So thanks for asking me to come speak about this today. We will, we'll talk a little bit about hydrocephalus and sort of how it presents in children and why and how this project came about. So hydrocephalus is the most common neurosurgical disorder in pediatrics and the most common reason for requiring surgery. And, it's for multiple reasons. We have children who present very early on in life with, congenital hydrocephalus. We have babies who were born premature, having an intraventricular hemorrhage, which is a high risk with these small babies, and having post-hemorrhagic hydrocephalus. We have children who develop hydrocephalus after things like brain tumors or AVM ruptures. So it really describes quite a wide variety of patients. It's important to understand not only are we dealing with anyone from, tiny little 2-kilo baby up to 18. Because of some of the risk factors for hydrocephalus in pediatrics, we also have quite a large population of developmentally delayed children who, assessment can be a little bit challenging. And as everyone knows, there are different surgical management options, but there's really no cure for hydrocephalus. Lifelong condition, often requiring multiple surgeries and hospitalizations over a lifetime. As I've kind of started to allude to, the management of shunt patients, it's not one group, but as a group, is really challenging. And for some of the reasons described, presentation of increased intracranial pressure is something that's relatively easy to detect in an adult or, a developmentally normal teenager, where they can describe having, onset of headaches, they can have level of consciousness changes, things that can, usually become quite obvious. As you can imagine, think of a baby. I mean, how are we to say that this baby's irritable and vomiting, and having symptoms which really overlap with just being a baby? You can imagine that it can be quite tough, and especially in developmentally delayed children. Same idea. We've got tube-fed children who can't talk. And presenting to hospital with symptoms that overlap with shunt symptoms is something that happens really, really regularly. Figuring out whether this child just has a virus that's making them miserable and vomiting and sleepy versus whether this is a medical emergency that could lead to, really severe effects if not treated, is exactly where our problem lies. We know that children with hydrocephalus are at risk of significant exposure to radiation over their lifetime. To get an MRI almost always requires sedation in anybody under 6, and even much older for a developmentally delayed population. And of course, even getting a CT scan, which is much quicker, same idea. Exposure to radiation, multiple anesthesia is a really difficult clinical problem that we deal with on a daily basis. So we know that, the clinical exam, the imaging, none of that is 100% to diagnose a problem with a shunt, which is where this project comes in. So I'll give you just a little bit of background on point-of-care ultrasound. So this is a project that we are working on collaboratively with the emergency room team at Sick Kids. Point-of-care ultrasound is something that the use of it has exploded for sure at Sick Kids, and I think multiple places around the world. They call it, the tagline is that the ultrasound is like the new stethoscope, kind of used for workup of anything under the sun. And so, and the use specifically of ultrasound to look at the back of the eye is also something that has been increasingly well studied. And as you can see here, the optic nerve that is continuous with the brain, surrounded by the same coverings, bathed in a layer of cerebral spinal fluid. So similarly to how an eye exam can detect papilledema or signs of pressure, originating from the brain, an ultrasound can actually pick up some of those changes as well. So, in terms of picking up signs of pressure, it's pretty well studied that ultrasound is effective at that. And I don't know if you can see too well here, but the big picture on the back, so on the ultrasound, you can see clearly that, the round, the globe, and then at the back, we have this, the band, the optic nerve that leads into there. So what we're studying in this project is both optic nerve elevation, which is sort of synonymous with papilledema, which would be bulging of the nerve into the globe. And we're also measuring the diameter of the optic nerve itself. So what we've found in our early studies, that even before you see papilledema or that bulging of the nerve into the globe, we see the actual diameter of the nerve itself enlarge. It's sort of a pre-papilledema finding and could be early detection of intracranial pressure. And here is sort of a little bit of a diagram of how that happens. And believe it or not, this is significantly easier to do in a non-cooperative patient or little baby. They can be screaming, they can be doing whatever they want, and it can still be accomplished pretty easily. And the technique, I'm not sure if I have a picture of that. No. The technique, essentially, we take a Tegaderm see-through sticker, put it over the eye, just to avoid gel getting in the eye. Not that the ultrasound gel is completely safe, but it's annoying. We take a clear sticker, put it over the eye, and then just place the probe directly over the eyelid. And we can get really, really quick, easy pictures. And we know this is safe, effective, and as we tell everybody who's worried about it, ultrasound is used on your baby before it's born. It's very safe. There's no risk that we know of, and it's pretty well studied. So just by placing the probe on the eye, we get photos similar to this. Sorry, I'm not sure if I included a good one to show you what papilledema looks like, but as you get used to seeing these, it's actually quite obvious. So rather than that nice smooth back of the eye, we would see a bit of bulging and along the back. And what really we're looking at even more so in this study is the nerve sheath diameter. So here's where we come in here. So just to introduce the name of our study, it's called the CHOOSE study, Change in Optic Nerve Sheath Diameter and Optic Disc Elevation as predictors of shunt obstruction in the emergency department. CHOOSE, much easier to say. And essentially we found in our early studies that because we're looking at a group of patients who have over their short lives been exposed to multiple variations in intracranial pressure with initial presentation, multiple blockages, and whatever else is their underlying disease, looking at just published standards of how wide that nerve sheath is supposed to be really was relatively meaningless for this group of patients. But using each patient as their own baseline has been really helpful. So what we do in this study, we see every patient that comes to our clinic when they're feeling well, they get their baseline ultrasound. So we take them in, it's 2-minute procedure, get some baseline images of their optic nerves. We have that on record. If they were to show up in the emergency room, then we go ahead and do a repeat of that ultrasound. And what we're finding is that we can really detect even just very small changes in the diameter of those nerves. Data is still coming in, but we're hoping that will be something that is really predictive of shunt problems. And, not only is this helpful for detecting shunt problem, but also quite the opposite. As you can imagine, we've talked about these babies that can come in once a month vomiting. We don't want to have to be exposing to radiation or putting under anesthesia every single time. So we're hoping not only that this will help diagnose real problems, but that it can also be used as a screening tool to help prevent unnecessary scans, unnecessary sedations in children that really don't need it, that fall into that other group of someone that just needs to take Tylenol and wait a couple days. So this is a big goal, and we know that we're collecting 600 baseline patients, and we have to collect somewhere in the range of 50 real obstructions to get our numbers. It's a work in progress. This is part 2 of the study. We've been going on for about a year so far. Early data has been really helpful. And, because we're hoping that even if this can help things, even for subgroups of patients, or even, make us even that much more confident about assessing shunt problems, that it will significantly benefit the patients. I think that is my 10-minute summary. Any questions? Yeah. Any questions? No? Yeah.
Are you comparing this to fundoscopy in pain health?
So in this specific study, no, that there have been studies done definitely to compare to fundoscopy, and it's extremely sensitive and specific in detecting papilledema. The nerve sheath diameter is not really information that you can get from fundoscopy, so not that part of it, but for papilledema, it's pretty well researched, yeah. There's also another study comparing it to opening pressure on lumbar punctures. So patients that are getting lumbar punctures just to check opening pressure, maybe in the future they can just get an ultrasound of the eye. So lots of work going on. Any other questions? Thank you.
Thanks so much, Sarah. She's heading back to work. If I could get everyone to pull out your smartphones or your phones, sorry, I don't know why I say smartphones, just pull out your phones for me. We're going to move actually into an evaluation. So we're going to skip, Christian and Michael, we're going to skip my presentation and move into the evaluation poll. So we're going to do something different at the end of today for our evaluation of the day, and we need to prepare for it now. So if you would be able to do the following actions before we head out for break, because it does take 5 minutes for the network to set this up. So if you could text the following message, WFNN Toronto 213, to the number 37607, you will be logged into our session. So the picture up there shows you in step 1 where the numbers should go and where the letters should go. And then in step 2, this is the picture you'll see after 5 minutes if you've done it correctly. So thanks for doing that. And when you've texted it, you're welcome to enjoy a 15-minute stretch break until 2:30, when we will reconvene. And just another plug as well, if you haven't already, try practice using those pupilometers off to the side here. Maybe get a picture doing one on your friends. It's kind of cool to do. This group here, I'm pointing at you. Okay, okay, thanks.